Dr. Azad Esack is the neurologist and neurophysiologist at Doctors Hospital. We're going to invite him up to do a presentation on tackling stroke and dementia, and specifically focusing on current measures and approaches for prevention. Let's welcome Dr. Esack.
Hi, good morning, folks. Nice to be here. Nice to see you all. Let me thank the sponsors for inviting me to give this presentation. I've always wanted to have lunch at the Ritz-Carlton. Just couldn't afford it previously. So what a great opportunity. Right. Let me hope this thing works today. Yeah. So point at that. Right. So when you're talking about any illness at all, and in terms of prevention, I think it's important you need to talk a little bit about the illness. You need to talk about some of its causative factors, the burden that it places on the health service and on the society as a whole, and how really cost-effective it is to actually implement this prevention. And there are some instances in some countries where certain diseases, there is no prevention, and therefore there are certain reasons for that, and that the taxes and the royalties received from the thing that causes these diseases are overwhelming. So there's no good reason for stopping that. So look, I am going to talk a little bit about dementias, not because I'm an expert on that, or not because I have that, but because I sort of know a little bit about it. And then I'm going to talk about stroke. Okay, so point to this one, he says. So what is dementia? Dementia is not really a specific entity per se, but it's rather the inability to remember things, to be able to think, and to be able to make decisions that affect our daily activities. Now, you may say, well, that definition applies to most of us, yes? And maybe it does, but let's take it a little bit further. You may have heard from Fiona McDougall, who's sitting somewhere there, last night, about what's the census for the Cayman Islands in terms of the numbers of people who are over the age of 65 changing over the last 10 years. And that number has actually increased by 85% over the last 10 years. It's going to quadruple over the next 10 years. And this is the age group where you have both of these diseases I'm going to talk about, both dementia and stroke. So it is, as this slide shows, it is really a tsunami. Right. So the brain population is growing, and worldwide there's 50 million people, rising to 170 million by 2050. The prevalence rate for dementia is about 6 to 8% if you're over the age of 65. And just to be a little bit dramatic, there's one new patient with Alzheimer's disease being diagnosed every 7 seconds. So the cost is enormous. What is the cost? So big numbers worldwide. It's about $1.3 trillion. That's I can hardly think of what that is. It's a lot of money anyway. And if it were the economy of a country, it will rank either 18th or 13th. And there's an error on this slide. I'm sorry about that. It's going to rank either 18th or 14th in the country. So big numbers. Right. So this is a study that was done by the London School of Economics, looking at attitudes to dementia in a very large population, 70,000 people, over 155 countries, and carried out by the LSC. And some of the findings were that almost 50% of the general public are concerned about dementia. And I can hardly read it. I think I have to go to my notes, I'm afraid. Please forgive me. Yeah, sorry. So 35% of carers across the world said that they have hidden their diagnosis from the family with the dementia. Over 50% of carers globally say that they are health. And that may be an understatement. Maybe more health carers are affected by this disease. And almost 62% of healthcare providers worldwide think that dementia is just part of the normal aging process. And the last one is the most interesting one. 40% of the general population think that doctors and nurses are demented. No, I read that wrong. I read that wrong. That should be 100% of the general population. No. Okay, so let's move on. So there are 4 types of dementias, essentially. So there's the dementia of Alzheimer's disease, which is the commonest. There's this interesting dementia called Lewy body dementia. And there's a triad for this Lewy body dementia. And I think it's as common as vascular dementia, and it's really a very underdiagnosed illness. And then there's frontotemporal dementia, which I'll mention very briefly. So Alzheimer's disease is an insidious onset illness. It usually presents with memory difficulties. The incidence is about 8% per year by the time you reach 85. And about 2/3 of the dementia is caused by Alzheimer's disease. The ultimate diagnosis is usually made on pathology, but with good PET scanning now, we could actually see that in the antemortem phase. Good. So here's the pathology. It's a normal brain. This is the brain of someone with Alzheimer's disease with neurofibrillary tangles within the cell and amyloidotic plaques within the parenchyma. And this is what the CT scan may look like. It's a lot of generalized atrophy. But a normal CT brain scan does not rule out the diagnosis. And in many instances, you do see a normal brain scan, even in older people. So, vascular dementia, second, or probably the third most commonest form of dementia, usually associated with vascular disease like stroke and diabetes and hypertension. It's a very abrupt onset and has this sort of stepwise look to it, course. Whereas Alzheimer's disease takes a sort of smoother course, the dementia of vascular disease takes a more stepwise course. And this is what a brain scan of vascular dementia with a lot of small vessel disease around the ventricles. And this is an interesting syndrome, dementia associated with Lewy bodies, which I think has a high incidence in vascular dementia. It's underdiagnosed. It's a triad. It's memory impairment, it's Parkinsonism, and visual hallucinations. Yeah. And some may add to that hypersomnia. If you're falling asleep, beware. Yeah? So visual, it's important to recognize this illness, quite honestly, because when these patients present with visual hallucinations and you give them antipsychotic drugs, they really, really decline very, very quickly, and you have to be really careful about not doing so. So the decline is faster than with Alzheimer's disease. So this is what the pathology looks like. There are these proteinaceous deposits within the cell, both on this stain and on H&E stain as well. And these deposits, what we call Lewy bodies, occur within the cerebral cortex of these patients, whereas the other Lewy body disease we know about, Parkinson's disease, those Lewy bodies occur within the substantia nigra, different part of the brain. So how do we distinguish the dementia associated with Parkinson's disease as opposed to Lewy body dementia? Well, the dementia associated with Parkinson's disease comes after the diagnosis of the motor syndrome, and by months or years, whereas the diagnosis of Lewy body dementia, the Parkinsonism, and the memory loss come together, or very close together. So, frontotemporal dementia is a rapidly progressing disease, as I seen in the younger patients. It used to be called Pick's disease many years ago. It's more progressive, it's more rapidly deteriorating. And let me show you the CT scan for that. And you can see the marked cerebral atrophy both frontally and temporally in these patients. So this illustration that looks a bit like a seahorse tells us a bit about the various etiological factors that contribute to the development of dementia. And this starts off in early life and with poor education, then it goes on to this interesting phenomenon, which was only described a few years ago, hearing loss and dementia. And I don't know many people understand that it is an important factor in the development of dementia. And when you see the person with the dementia, it's something that you need to treat. Yeah? So there are other factors as well, such as trauma, hypertension, alcoholism, which we're going to talk a little bit about, obesity, smoking, depression is very common, physical inactivity, social isolation, air pollution, a very strong one, and diabetes, and all contributing towards the dementia. Okay? About 60% we don't know why. So the Johns Hopkins people, about 8 or 9 years ago, produced this paper linking hearing loss and dementia. And I hope you guys are listening, right? So why is that so? Well, it's probably linked to a common etiology such as microvascular disease, also to reduce social engagement because you're not hearing, you tend to keep away from people, maybe changes in the brain with impairment of cognitive load, giving rise to impaired cognitive functioning. The other factor that's not mentioned in that sort of seahorse diagram that I showed you is this concept of sleep apnea and dementia. And this is a very recent study, published in April of this year, linking sleep apnea and the risk of dementia. And you'll see it again when we talk about vascular disease of the brain. And there's a third neurological condition associated with sleep apnea, and that's epilepsy. So there are 3 things associated with sleep apnea. One is dementia, one is stroke, and the third is epilepsy. So there's an increased risk of Alzheimer's disease, there's a decreased risk on CPAP treatment, and there are pathological changes before the dementia in these patients who've got sleep apnea. So there are other sleep disturbances associated with dementia, and these may include nightmares, night terrors, inability to sleep, insomnia, and as I mentioned previously, in Lewy body disease, hypersomnia, sleeping many times a day, may be something to look at. And these these sleep disorders may predate the onset of the dementia by months or years. Yeah. So a lot is talked about alcoholism and dementia and the relationship of the two things. I want to show you this woman who's in her 50s, who was the manager of a large British hospital, and she was brought in by her relatives to see me because her memory was going. And I want to just play it a little bit to show you.
What happened is, I'm not really could read and write properly, but the big writings, I don't like to wear glasses. The lenses inside burned my eyes. When they put me as senior manager, beside I was managing between hospital patients and
can you stop
geriatric.
Good. So what she's doing there is something called confabulation. And she's shifting from one subject to the other because she can't remember the thread of the subject. So she makes things up as she goes along. And that's a good example of confabulation in a syndrome called, this way, Korsakoff Syndrome. You remember that, maybe remember that term. And it's alcohol and thiamine deficiency related. The hallmark of the disease is this confabulation. But interestingly, we now know that there is an APOE4 link. And that's the gene that's related to early onset Alzheimer's disease, patients who develop Alzheimer's disease who are less than 50 years old. So alcohol may be a catalyst in the development of Alzheimer's disease. Have I gone back? Yeah. So the treatment, in terms of prevention, no magic to it. You minimize the vascular risk factors such as diabetes and hypertension. You try and prevent head injuries. You stop people from smoking. You try and reduce air pollution. You maintain frequent exercise. You reduce the occurrence of depression, and sometimes depression can be really, really very difficult to diagnose in the patient with dementia. And you avoid excessive alcohol intake. You treat the hearing impairment, and that's new. That's something we need to be wary about. We also need to treat the sleep apnea. Yeah? And we try and maintain frequent social contact and try and attain a higher level of education. So these are just the same thing that I've just said, really targeted at individuals, treating the hypertension, looking at the hearing loss, discouraging drinking, stopping smoking, reducing obesity, and increasing physical activity, especially in the midlife. It's something that finances is something we tend to forget when we see patients with dementia, and it's really very sad because when the dementia progresses and the family haven't got a clue what he or she, the patient with the dementia, owes to the bank or to whoever, or what other people owe to him, and what are the finance situations. And I suggest that this is something that needs to be looked at very early on when you're looking at someone who has a dementing illness. On a broader scale, there are strategies to recommend it to on a much wider scale. Okay. So this is, I think, a very sad kind of scene where you've got older people in a very stark room, kind of sleeping on themselves, and it's kind of sad. And what they then do, right? So they then wheel them into a television room, and the TV starts to look at them, you know. And then, well, what they then do is to bring the musician along, right? And this lady is praying that he will stop. And this one, well, he's giving her such a headache that he... And because he's not a rap singer, they're all kind of tired. And so they bring along the dog, right? Great. And they all wake up, right? This dog, right? And he says to the lady, hey, lady, I've kind of had a rough day. Can you just go easy on me? And of course, he goes to sleep in front of the TV. He's so tired. Right. Okay. Stroke. Let's do stroke. This is a CT brain scan showing a very large right middle cerebral artery infarct. And I want you just to remember this scan because the last patient I show, this belongs to him. So about 65 to 75% of patients who have stroke have a cerebral infarct. A smaller number have brain hemorrhage, big hemorrhage that's gone into the ventricular system. And an even smaller number have what's called a subarachnoid hemorrhage, where there's bleeding into the subarachnoid spaces. And this really carries a very high mortality, about 60% on first presentation. So worldwide, stroke affects poorer countries by and large. And if you look at the incidence, they have very high incidence in places like China and Russia. It may reflect the high levels of smoking, the high levels of hypertension, yeah, and general poverty in certain areas. This is an illustration just highlighting some of the cost to stroke, big numbers, what happens in poorer countries, big numbers again, starting findings there. Yeah. One in four people likely to have a stroke at some stage in their life. That's really quite a scary thing. And 1 in 6 deaths from cardiovascular disease, as Dr. Ravi was telling us about, is due to stroke. And the reverse is also true. If you've got a heart attack, if you've got a stroke, you are 1 in 4 chance of dying from a heart attack. So these are some graphs that show, tell us that in wealthier countries, the morbidity, mortality is getting better with time as time goes on. But in the poorer countries, the same does not apply. Yeah, the same does not apply. So stroke is more common in more low and middle income countries, they're less well educated. Blacks are twice or in some cases 3 times more likely to suffer stroke than white people. And if you think stroke doesn't occur in young people, well, in 10% to 15% of stroke, it's between 18 to 50 years old. This just shows us the rising incidence of stroke, both all strokes and both ischemic stroke. And somebody's doing a good job by moving the slides, huh? It's really good. And so, poignant map showing a high prevalence of patients with stroke in this part of America. And can you guess why? Yeah, this is where most of the Afro-Americans live. Yeah. Okay. I like this table because it tells you a bit about, these are some World Health stats, about what happens to the death rate per 100,000 in certain countries. And if you look at the United Kingdom and the United States, in 2020, the death rate per 100 is about 20.17, 22.27. Yeah? In Switzerland, believe it or not, it's actually much lower. Maybe due to the Rolex watches, I don't know, maybe something. But in Jamaica, it's actually much higher. And of course, in Central Africa, it's way over the top, 181. So here are the usual factors and certainly hypertension is way far now. Air pollution, you don't think about it a lot, but it's there, and all the other risk factors that we've alluded to previously. So there's some irreversible causes of stroke, and this is age, gender. That's kind of not so reversible. That's kind of reversible nowadays, isn't it? Yeah. Yeah. The family history we sometimes like to get rid of, but it's difficult to get rid of them. And of course, ethnicity, and there are some people who've tried to change that as well. You know, MJ, okay. But there are some, sleep apnea again comes around with this thing where there's an increasing association. CPAP therapy is beneficial in stroke improvement. The more severe the sleep apnea, the slower the recovery from stroke. And therefore, you must address sleep apnea when we try to manage patients' stroke, something we don't ever do. And sleep apnea is involved in all these different considerations with obesity and diabetes and dyslipidemia giving rise to stroke. Next. Right, so why? Well, when the brain becomes hypoxic or hypoxemic, it creates cardiac arrhythmias. There's certainly a fluctuation in the blood pressure throughout the night in patients who've got sleep apnea. And because of this hypoxemia and hypoxia, you've got a strong inflammatory process giving rise to platelet mobilization and clot formation. So, next. I'm often asked about the oral contraceptive pill and stroke. And I thought I'd just put this up out of interest. This young woman came to me a couple of years ago with acute onset of headache, vomiting, visual disturbance. And she was taking a pill called Yaz. And I think a lot of people are familiar with Yaz and Yasmin, right? Yeah. Anyway, so next, please. Yeah. So this was a CT brain scan. And it shows a small hemorrhage into an infarct in the right occipital area. And when you see that in someone who's on the pill, you think of a venous stroke, not an arterial stroke. And so she went on to have, next, an MRV, which is an MRI with a venous phase. And this is the superior sagittal sinus, the transverse sinus giving into the sigmoid sinus on the left, and on the right, it's just cut off, gone, kaput, blocked it off. Yeah. So the oral contraception and stroke is important, especially with this combination of estrogen and this drug, and this progestin called drospirenone, and that's found in these two pills called Yaz and Yasmin. But if you combine this with smoking, an older woman, and migraine, it really does increase the risk of having a stroke. Next, please. Yeah. And we had about 5 patients, young women who had stroked out on Yaz and Yasmin, and we were attempting to publish the series, and we were blocked because the case against the company was in the courts, and there was a settlement of over 19,000 claims of Yaz resolved in the United States in 2019. So something to think about. Stroke complications, lots. Death being, of course, the worst. 28% at 1 month, 40% at 1 year, 60% at 5 years. a lot of disability, a lot of neuropsychiatric effects, especially depression, anxiety, and crying. Post-stroke crying is very common, and it's not that difficult to treat with SSRIs. Dementia, 10% acutely and 30% in 1 year. Incontinence, Parkinsonism leading to falls. Pain from various descriptions of financial difficulties. And this is very unusual and very rare syndrome called foreign accent syndrome. And just out of interest, I'm going to try and show you an example of that. Okay, next. Education. If you want to prevent any disease, there are 3 things you have to remember. You have to do. You have to have education. You definitely have to have education, and you must have education. Without those 3 things, you really are. But the question is, who provides that? Who provides the education? Does it come from the Ministry of Health, or the government, or the private hospitals, or the public hospitals, or the NGOs, or I don't know, the banks, or what have you? I mean, perhaps all of them. And maybe you can have some ideas about that. It's really important to try and get the patient to hospital, and many people who treat stroke now have a dedicated ambulances that bring these patients to hospital. And there should be an early warning system in play, whereas if you have a patient who's coming from the community to hospital, that everybody knows that patient is around, so radiology is given the heads up, the neurologist is given the heads up, and certainly the emergency department. So factors that reduce the morbidity and mortality acutely, I'm all in favor of the stroke unit. I started my training in one of these, and early diagnosis, again, thrombolysis, clot recovery, we'll see that a bit. Carotid endarterectomy, I'm really for this. Head cooling, contentious. Early attention to swallowing. Swallowing is really crucial in the acute phase. And it's very sad to see patients being fed patients with bad stroke, be it cortical or brainstem, being fed so early on, and aspiration being a big problem. The judicious care of blood pressure lowering, diabetes, and again, sleep apnea. Next, please. So, this is one of the very earliest stroke units in the United Kingdom, in Bristol, a French hospital. This is where I started my training, 2 centuries ago. Next, please. But it has morphed. It's gotten to something slightly better, you know. And there's a lot of rehab work going, spinal injuries, head injuries, stroke, etc. in this unit now. So that stroke units play a very important part in improving the quality of life. There's this study done way back in 1998. Next, please. And this graph shows that people who come from a stroke center, they're more likely to get back at home earlier than those who do not. Reperfusion studies, yes, TPA, thrombolysis in the first 4.5 hours window is meant to be cost effective, and that's why we need to try and get these patients to hospital as soon as possible. But I'll show you a way by rapid scanning where, and if you know where the penumbra, the area around the stroke, if it's not too large, you might be able to extend this time period, and that would be extremely helpful. And those studies are ongoing at the moment. Mechanical thrombectomy is trying to put a catheter into the arterial system and either recovering the clot or lysing the clot with thrombolysis again. But it's only cost effective if you can do that within a 6-hour period. Next. So, I am all for acute endarterectomy. We've done quite a lot of these in the past. And I want to show you an example of why this is so important. 55-year-old woman with hypertension and very high LDL, Dr. Ravi, very, I didn't see you, of course, presented with left eye pain and a very fluctuating weakness of the left arm. Hey, within hours, the arm is weak, can't move it, and back to normal again. Evolving stroke. CT scan normal, but if you've got a good ultrasonographer, and you can do quick carotid Dopplers, this is what you get. So this is the ultrasound of that lady. That's her external carotid. This is the bifurcation of the external carotid and the internal carotid. That's the internal carotid. That's the vital part. And there is that clot sitting within the internal carotid. And on the day of presentation, she came to surgery, had this done under local regional anesthesia, wide awake, and this is what, next please, this is what we took out. This is clot, this is the plaque, there is a fresh clot, and you could envisage little bits of this just popping out, until a large bit goes, and she gets a massive stroke. So it's a very, very important thing to try and look for carotid artery disease, especially in patients who have both hypertension and diabetes. Next, please. We were able to report our cases way back and of endarterectomy acutely, and that was part, next, please. Next, please. And this is part of a larger series that we published in the British Journal of Surgery, cost effectiveness of carotid endarterectomy, looking at over 200 patients, all done under local regional block, all wide awake. Next, please. Good. So I want to show you, is there a time remaining, 24 minutes? Oh, we have lots of time. Oh, yeah. Oh, we get to lunch sooner. Yeah. Ooh. I'll just have a drink so that. Yeah, I'll be done soon. You know, like Henry VIII used to say to his wives, I shan't keep you long. So listen, let's be serious here now. This is you know, this is the Ritz-Carlton, you know. So listen, this guy, this is a man who's a Filipino, and as Dr. Ravi told you, this is one group of individuals who vascular disease is very prominent in. He pitched up to our hospital about a few weeks ago with a left cerebellar stroke, very unsteady. The CT scan on admission was normal. He then, at the same sitting, having the CT scan, he had perfusion studies done and an angiogram, all done at the same time, and all within 5 to 10 minutes. Remarkable quick scanner. I can give you these beautiful images of perfusion defect within the left cerebellum. Normal CT brain scan. Yeah? Next, please. And this is his angiogram. Pretty pictures, and that's the anterior inferior cerebral artery that's blocked. Nice and easy to see. And this man did extremely well on thrombolysis. So I was telling you about this 4.5-hour business. And if you can do the perfusion studies and do them quickly and reconstruct quickly, then you can get an idea of what the penumbra is, the area around the stroke. And if the area around the stroke is not large, like this one, then there is a strong possibility of extending the period of time that you can use thrombolysis effectively. And there are some ongoing studies in the States now looking at that same issue. Next, please. Right. So around the time that I started doing neurology in the UK, the Oxfordshire Stroke Project came about. And this looked really at trying to get patients out of hospital into the community. And we were actually admitting patients from casualty into the community with stroke. Yeah? And it was because we had backup. We had all these people who in the community that was involved. We had the occupational therapists, physiotherapy, speech therapy, incontinence nurse, blah, 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 blah. All these people were involved, and there was a good system of doing that. But that takes a lot of effort. That takes a lot of effort and planning. I'm not sure in the Cayman Islands whether that works, and I'm kind of, I need some guidance on this, whether having insurance actually makes that easier or less easy to do, because, well, the insurance companies can tell you about that. But this is something that really needs, this is something that can be addressed, the community approach to management of stroke. Okay, next, please. Right, so this is a wagon wheel, saying basically what we've all been saying, telling us about population-wide strategies that includes exercise and reducing LDL, etc., looking at good drugs, and then individual strategies to try and reduce hypertension and obesity, etc. Yeah. Okay, I think we're almost there. Yeah, oh, right, okay. We're almost there, we really are. You know, neurologists like to talk about esoteric things. It's within their 2% of the DNA. You remember that? Yeah. It's what they do. And I have to share this patient with you because this illness is so rare. This man is 55, or was 55, a senior economist with the government, spoke lots and lots at all kinds of meetings, trained at the LSE, quite a good speaker, came with a big stroke, and that, if you remember the first scan I showed you, that's him. Big right MCA infarct, almost died. We ventilated this chap, and he eventually did very well. And so his wife brought him back to clinic to do, and she said to me, "Doctor, this man is speaking kind of weird. Why is he speaking like that? What you done with him?" I said, "Well, let's have a look."
Yeah, a little weak. I think I'm a little weak. I feel like I'm getting the virus. She gets the virus. My next son gets the virus. And you know, tell like he has virus. That's how he prove. Dr. Rufner, I tell you have virus. Don't say where you father, you go here. Dr. Rufner, I tell you put the antibiotics.
You can stop it now, please. Good. So, you can see that he's got a left hemiparesis. You can see that he's emotionally upset, and he's got a bit of stroke, post-stroke crying. But this isn't the man that was talking. This isn't the economist that talks every week. Yeah? So what's his accent? Can anyone guess? Don't tell me he's mocking me. No, that's not right. That's not fair. That's not fair. Yeah. I got Trinidadian. Japanese? No, I didn't get it. Anybody from Grenada? Anybody from Eastern Caribbean? This is a profound Grenadian accent. This man has never been to Grenada. Yeah, never. And I can tell you, we have some videos of this man speaking the Queen's English before all of this. Yeah. And this is foreign accent syndrome. Yeah. And I've had two other patients in my career. One, a lady in Yorkshire who developed a stroke and started speaking with a German accent. And I've had a young boy of 10 with a head injury with a prominent American accent. So it's just out of interest and just to try and keep the boredom away. So next. Next. Yeah. Right, so nice sunrise over Cayman, yeah, okay. Next. Right, so we're done. What I like to do is not for you. What I like is for you not to ask me any questions. I don't like questions because I can't answer them, quite honestly. But I would implore you to make suggestions and or comments on your own personal things. I mean, really, dementia and stroke. Yeah. So let's go. Thank you very much for your time and for the company.